Good sharing. Just 1 second, sir.
Okay, okay.
And I've seen. It's not working. Sir, just loading, sir. 1 second, sir.
No
Not correct.
problem. Take your own time, no problem.
Mr. X, 60-year-old male, hailing from Cuddalore, who's a shopkeeper by occupation, um, 12th standard, educated till 12th standard, came with chief complaints of increased frequency of micturition since 6 months, dribbling of urine with a weak stream of urine during micturition for 6 months, and complaints of burning micturition for 1 week. History of presenting illness. The patient was apparently normal until 6 months ago, after which he started experiencing increased frequency of maturation and had to wake up 3 to 4 times at night to pass urine. He also had increased urgency of maturation along with a senses of incomplete emptying of bladder. Patient had history of urine retention 6 months back and was catheterized for 1 week at that point of time. He was started on medication tamsulosin 0.4 mg plus dutasteride 0.5 mg once a day. History of burning micturition for the past 1 week. No history of blood in urine. No history of straining while passing urine. No history of fever, abdominal pain, or vomiting. No history of weight loss or loss of appetite. No history of cold, cough, breathlessness, chest pain, syncope, or swelling of feet. Past history. Patient is a known case of hypertension since 10 years on tablet telmisartan 40 mg OD. No history of diabetes mellitus, bronchial asthma, tuberculosis, ischemic heart disease, thyroid disorder, or CVA. No history of drug allergies. Personal history. He takes a mixed diet. Sleep is disturbed due to the nighttime awakenings to pass urine. Bowel habits are regular. No history of smoking or alcohol or substance abuse. Surgical history. No history of past surgical procedures or exposure to anesthetic drugs. Family history. No history of any similar complaints in the family. Summary. Mr. X, a 60-year-old shopkeeper from Cuddalore who is a known hypertensive on medication for the last 10 years, came with complaints of increased frequency of passing urine and dribbling of urine for the past 6 months, with burning of cessation while passing urine for the last 1 week. Was diagnosed to have benign prostatic hypertrophy and is planned for TURP. Shall I continue, sir, to the examination?
Mainly, positive findings in your examination.
The positive findings is that he had.
We'll go with this and important findings. What is required for your anesthetic management? You can always talk about.
Sir, for examination, for examination, patient had the first slide. Patient's moderately built and nourished male, sir. Height of 170 centimeters, weight of 65 kgs. Venous access is good, and he's comfortable at rest. He has no history of any palar icterus sinus clubbing, and he's on urinary catheter for the past 4 days right now. Vitals. Currently, blood pressure is 150 over 90 in the right arm, measured in supine position. The pulse rate is 82 beats per minute, regular rhythm and good volume. No specific normal character and no radiator or radiofemoral delay. Respiratory rate is 16 breaths per minute and saturation maintains 99% of room air. Temperature is normal 8 February, sir. Airway examination is normal, sir. There's no facial dysfunction.
Okay, right.
Next. Spinal examination also is normal, sir.
Fine.
Systemic examination, abdomen is soft and tender. External genitalia is normal and PR was not done. CBS, RS, and CNS are normal, within normal limits.
Okay.
Final diagnosis. 60-year-old shopkeeper from Kadlur who's a known case of hypertensive on medication for the last 10 years. Diagnosed with benign prostatic hypertrophy is planned for TURP.
Okay, so with your history, basically he's on two drugs
Yes, sir.
for his prostate, and for hypertension, one of the drugs he is on, isn't it?
Yes,
So
sir.
he's on tamsulosin and what else he is on? Yeah,
Just try.
dutasteride he is on. What is tamsulosin?
So it's a alpha 1 inhibitor, sir. Alpha 1 blocker. It
Okay,
blocks predominantly
selective alpha
prostate
blocker.
specific. It's a prostate specific alpha 1 blocker, alpha 1 A blocking, sir.
Okay, and dutasteride? No, because you only because whatever the drugs the patient is on, you should always know about how. That is what as anesthetist, you have to know everything. That is a
Yes, sir.
problem with us, or it may be an advantage also. So it is an anti testosterone.
Okay, sir.
So that's how it decreases the growth of the prostate, and also it shrinks the prostate. So that is why many of these patients can be on anti-testosterone also. And of course, this alpha 1 selective alpha 1 blocker, tamsulosin, also will shrink the prostate and improves the passage. It's always there. So should we continue these two drugs on the day of surgery, or should we stop?
Yes, sir. We can continue both the drugs in the day, sir.
We can continue because tamsulosin systemic effects are very minimal. So it's an alpha 1 blocker. It is not like prozosine or terazosin or doxozosin. They have more of effect on the peripheral arterioles, and this may not have much effect. So you can continue. Anti-testosterone drug, absolutely no problem. You can continue. So whereas the other drug, the patient is on, tell me, sir. What about
Yes,
that drug? If the patient is posted for TURP, would you like to continue, or would you like to stop it on the day of surgery?
Sir, I would like to stop it on the day of the surgery, sir, because telmisartan will be associated with. I will be going most likely for spinal for this patient. Chances of refractory hypotension are very high with the AC inhibitors or ARBs, sir.
Yeah, when do you want to restart then?
So I would like to restart 24 hours after the surgery.
No. As early as possible, you have to restart. Because otherwise, the patient will not be on any antihypertensives.
Yes.
Certainly, the blood pressure may shoot up in the postoperative period. That
Yes,
can produce one of the complications. The postoperative period in TURP is bleeding. So
Yes,
the
sir.
patient may have a lot of bleeding. So that's why, as early as possible, once the patient can take orally, because you are doing under regional anesthesia, you can definitely give in the postoperative period. Absolutely no problem. So that is another thing about that. One more thing which is lacking in your history is you have not assessed the meds of this patient.
Yes.
Invariably, you have to write down what is the, because there are a lot of these geriatric patients, hypertensive patient, invariably you expect them to have coronary artery disease. Is right.
Yes, sir.
So once the patient has coronary artery disease, it is, you are one of the, and TURP is not a minor procedure or a low risk surgery. It is definitely an intermediate risk surgery. And so it is always better to know about the meds. Based on the history of meds, you require to go for additional non-invasive cardiovascular tests, or you need not have to do. So that is why that always, in these patients, geriatric patients, you always get this thing done. Now, whenever these patients are posted for TURP surgery, what are your concerns? First we will, discuss about the concerns, then we'll go for investigations, preparations, and management. Okay, what are your concerns in these patients when they are
Sir,
posted?
yes, sir. With the TURP surgery specifically, one first concern is that the patient is of the geriatric age group. So any issues associated with geriatric age group, I'll be concerned about.
All physiological changes
Yes, sir.
occur in geriatrics. You have to keep it in mind. We'll not discuss much about this geriatric physiological changes, because we'll discuss this when we discuss cataract surgery. That we'll be discussing as geriatric patient only, short case. So let me discuss that there. But majority of these patients are geriatric patients. There can be even 80, 90 years, isn't it? And
Yes,
I have given anesthesia for a 98-year-old man also for TURP. So you can have real geriatric patients. So all physiological changes in geriatrics you should understand, and that is one of the concerns. Okay, what is the second concern?
Second concern is in our patient, obviously hypertension is a concern for us. So any hypertensive
Otherwise,
urgency or emergency perioperatively.
otherwise,
Otherwise, for
in general,
TURP, positioning is
in general,
concern.
multiple comorbid conditions.
Yes.
They can be diabetic, they can be having ischemic heart disease, they can be hypertensive, they might have had, many times because of coronary artery disease, vascularization, revascularization procedures like stents or CABG, or they may have even pacemakers. Many times in your theory, that is what is asked.
yes,
A
Yes.
patient with a pacemaker posted for TURP, how do you manage? Isn't it? So these patients can be having multiple comorbid conditions. That is the second thing. The third thing is because they are having multiple comorbid conditions, they can be on polypharmacy. They can be on multiple drugs. And you have to have that concern about patients having multiple drugs they are already taking. So that is the third concern. What is the fourth concern? You are talking about something.
Positioning, sir.
Positioning during
Yeah.
surgery.
Lithotomy position is
Before positioning, what kind of effect on the kidney this prostate can produce?
Can increase the serum creatinine because of obstructive
Obstructive
nephropathy.
neuropathy. The patients can have problems of post-renal failure. That is what we call it as. Because of obstruction, because it is producing an obstruction. So obstructive neuropathy, it can affect both the kidneys.
Yes, sir.
Because obstruction is in the urethra.
Urethra.
Both the kidneys will have the back pressure effects. So the obstructive neuropathy is one more concern. And then another concern, lithotomy posture.
Lithotomy.
Yeah, regarding lithotomy posture. One more now with the TURP. What other concerns?
TURP syndrome, sir, with
TURP
our
syndrome
irrigation
because of
fluid.
the irrigation fluid. So these are the concerns. Many times as examiners, what we ask you is, what are your concerns for these patients? Because once you know the concerns, you know how to prepare this patient, how to manage this. So these are all the concerns. So lithotomy position itself is a concern. Then the patient may already have a higher, creatinine levels. That is another concern when you are preparing this patient. Plus, TURP syndrome. Of course, we rarely see TURP syndrome, but always you'll be asked about this. And even in theory, you will have a TURP syndrome as a short notes also. And lithotomy posture is still a problem in these patients, geriatric patients. Okay, one by one, we'll go into details afterwards. Okay, now this patient is posted for TURP. Obviously, he has got a benign prostatic only. There is some echoing.
Sir?
Echoing as a
No, sir. It should be all right. Mic is on.
when I talk, now it is not there. Now it disappeared. Yeah, maybe some there only. Okay, so how do you investigate this patient and how do you manage? Directly we'll go for management.
Okay.
Because
So,
physiological changes I should have discussed, that I'll discuss later.
yes, sir.
Hmm.
Sir, so with respect to investigations, I would like to go ahead with a complete blood count just to see a baseline hemoglobin. I would like to say WBC count to rule out any
Hemoglobin
infection.
important in these patients?
Yes, sir. With the elderly patients, they can have an anemia baseline, sir.
And
Might be
also with
nutritional.
TURP, there can be increased bleeding. So the
yes.
surgery is associated with increased bleeding.
Because
So we'd
TURP,
like to know.
yeah, you can expect
And
the blood loss. So another problem is TURP.
we won't be able to find out how much blood loss.
Assess the amount of blood loss. So that is why hemoglobin or hematocrit is very important, initial baseline hematocrit. And also to calculate the blood loss,
Yes, sir.
require initial hematocrit or hemoglobin.
Yes,
A calorimetric method, what you have to use. Okay. Hemoglobin. And again, whenever there is an obstruction, they are prone for infection.
infection. Yes, sir.
Isn't it? So that is
Yes.
why total count, differential count becomes very important.
Important.
Okay. So suppose
Yes.
the total count and differential count are high. So
Yes.
should
Yes, sir.
you take him up just like that tomorrow is the surgery? Or should we treat him and then take him
No,
up?
sir, should start him on antibiotics
After seeing,
after urine routine and culture.
yes,
Yeah. What happens if you don't treat the infection and then take him out?
post-operative septicemia is higher risks.
Very common. Sepsis and septicemia is very, very common. And you have to treat this. And many times, the antibiotics may not reach the prostate. That is another problem. Whenever they have a prostatitis, it may not reach. But if they have infection in the bladder or the kidney because of the obstruction, so that has to be treated before taking up. Okay. So, okay, total count, differential count, fine. Then,
Yes, sir. So after that, I would also like to do serum platelets just to know a baseline.
okay.
And after that, I would like to do a renal function test of urea and creatinine to rule out any post-renal AKI.
Okay, so patient has now presently his blood serum creatinine is 2. He has
Okay,
come
sir.
with, to the hospital with an obstruction. His serum creatinine is 2. Shall we take him up for surgery or because the cause is obstruction?
Yes, sir.
We can't take him for surgery because only if we clear the obstruction, the creatinine is going to come down.
But you can clear the obstruction by placing a catheter. You need not have
But
to.
more the catheter is there, the risk for infection is more.
No. These patients, because once their creatinine level is high, they'll also have hypervolemia. You know that is already a derangement in the kidney functioning because of the obstruction. So you have to see that the creatinine levels come down to near normal before taking up. So you can even place a catheter and send him home and ask him to come after 15 days or 20 days, repeat creatinine. Because if the creatinine level is high as a result of obstructive uropathy, these are the patients who are likely to develop intraoperative or perioperative TURP syndrome. Because they just cannot tolerate any extra volume. Already they'll have hypervolemia. So this is one of the common questions you'll be asked in the exam. So you don't say that. You always say, I'll relieve the obstruction by putting a catheter and advise him to come after about 2 weeks, repeat creatinine. And based on the creatinine, either to continue 1 more week or so, you can decide later. Okay, fine.
Is there a limit, sir? Is there an upper limit after which we have to send them home catheterized?
No,
Yes.
usually if it is more than 1.5, usually better to catheterize and then bring it to near normal.
Okay, sir.
You think that serum creatinine increase is because of the obstruction. Suppose
Okay,
if it
sir.
is because of the other reasons, like patient already having a diabetes, diabetic nephropathy and all. So then you can try, definitely place a catheter and then wait for 1 or 2 weeks to see the creatinine comes down or not. If it is due to obstruction, it will come down. If
Okay,
it
sir.
is not due to obstruction, it will not come down. Then with risk, you will have to take up the patient.
Okay, sir.
Okay. Then, right.
Then coming to electrolytes, serum electrolytes, I would like to ask for, sir, especially obviously for to wrote any to see a baseline of sodium, sir.
Sodium, very important,
Yes.
because you expect a dilutional hyponatremia. So that is why you should know about the basal electrolytes, sodium, potassium, all electrolytes, right?
Yes.
And also I would like to do after that I would also like to do an ECG and
Right.
to rule out any to see a baseline ECG and to rule out any presence of any arrhythmias or dysrhythmias. Seeing as the patient is of a geriatric age group, I would like to also go for a 2D echo to rule out any regional wall motion abnormality, to rule out any diastolic dysfunction, and to look for any systolic dysfunction as well. So
And left ventricular hypertrophy because this patient's are
hypertension, yes.
And also you can even do a stress echo or stress ECG depending on the METs.
Yes,
Yes.
sir.
That is why
The
METs
METs is
becomes
lower.
very important.
Yes, sir.
Assessment of the METs by history becomes very important.
Very
Okay,
yes.
what is the exercise tolerance in this patient, physical capacity, METs?
It was 4 to 7, sir.
Yeah, it was more than 4.
Yes,
Then
more than 4.
required to go for a stress ECG or stress echo is not required.
Yes.
Right. Right.
Then random blood sugar, because this patient's 60 years old. So we'd like to rule out
You
any.
go for FBS, PPBS. Why random?
Okay.
Random, you will not get any much information. It is always FBS, PPBS.
Okay, sir.
Okay.
Then blood grouping typing and serology, sir.
That is very important. Type with serology plus, coagulation profile.
Profile.
Coagulation.
These patients are highly prone for DIC in the postoperative period. So it is better to have a coagulation profile, basal coagulation profile done before taking up for surgery. These are all indicated tests in these patients. Okay, so you have done all these tests. Now, thing is you may have to take up the patient for surgery. So what kind of anesthetic technique you are planning for?
So I would like to go for spinal anesthesia.
Okay, spinal you want to go for. Okay.
Yes, sir.
So
I would
why
like to achieve.
spinal first?
Sir,
not?
spinal, because the patient will remain awake during spinal. I can rule out any CNS symptoms that may occur due to TURP syndrome intraoperatively if it occurs. So it may not
Early
be the
detection. You can
early
always
detection
test
part here.
early detection of TURP syndrome. That is one
Yes,
of the things. Okay, then
yes, sir.
other advantage.
Second thing is bladder rupture. I would like to maintain a level of at least T10. That way, if the patient experiences a bladder rupture during surgery, then they will be able to feel the pain. They can complain about it, and we will be able to intervene earlier. So.
Bladder rupture or bladder perforation?
Perforation, sir.
Yeah,
Perforation.
yeah, because by the resectoscope, sometimes the bladder may get perforated. If the urologist is not very careful, so there can be, and immediately there will be diaphragmatic irritation will be there. The fluid will go and irritate, and otherwise also, the pain of the bladder perforation passes through the C5, which I told you, telling you that quite resistant to our spinal or epidural.
Yes, sir.
So it is what is called an epidural sleeve or a spinal sleeve. Now again, we are having some echo is occurring.
1 second, sir. We'll just switch the.
We'll just go to a different system. Just a second, sir.
Okay.
It's okay. Is it okay, sir, now?
It's okay, I think.
Yes, sir.
So where were we? Regarding spinal anesthesia.
Bladder perforation, sir.
So advantages of spinal anesthesia. So these are some of the important advantages of regional anesthesia. That's why, mainly in these patients, early detection. One more advantage of spinal is when you produce spinal anesthesia and sympathetic block, what advantage will be there in a TURP patient again?
Positioning
venodilatation, isn't it? You are going to produce venodilatation.
Yes, sir.
So,
sir, because of that, the pressure in the dependent area on the operative side will be more. So the amount of absorption of irrigation fluid will be lesser, sir.
No, what happens to, you said that the pressures in the venous sinuses will be lower, isn't it? So absorption can be higher. That is a disadvantage actually.
So blood loss will be.
It's the one advantage by producing a sympathetic block and producing venodilatation is the extra amount of fluid that gets absorbed can get accommodated. Now, one of the problems in TURP is the circulatory overload, pulmonary edema.
Yes, sir.
So that may be reduced when you are producing a sympathetic block and producing venodilatation. So that is another advantage you can always quote as far as your regional anesthesia or spinal anesthetic technique. And what about post-op analgesia?
Post-op analgesia, we can give morphine in the spinal, sir.
No, that is another advantage. If you can add buprenorphine or morphine, so you will also have a prolonged at least more than 24 hours of post-op analgesia, which is another advantage with regional anesthesia compared to GA. We are comparing with GA.
Yes,
As the patient wakes up, there won't be any analgesia. So with spinal, that can also be there. Now, why not epidural?
Sir, with epidural, the sacral sparing is a problem, sir. And
One is sacral sparing.
prostate is
technically-
primarily innervated by sacral fiber, so we will have
technically more difficult,
Yes.
isn't it? There is no definite endpoint, and failure rate is high. So these are some of the drawbacks of epidural. Of course, you can go for combined epidural analgesia also, isn't it? So any regional analgesia anesthesia technique is ideal than GA. So, but GA is not contraindicated as such. But because these patients are again, will have multiple comorbid conditions, they can have polypharmacy. So that is how, GA may not be ideal. But if the patient's left ventricular ejection fraction is very low,
Yes.
then ideal would be for GA only. You will not go for regional anesthesia. So that is what, you will have to individualize your technique based on the patient. Okay. Now, the other thing is, what is the blood nerve supply of the prostate, and what is the level you have to block? You said T10. So why T10?
So the prostate's nerve supply is predominantly from S2, S3, and S4, but the bladder's nerve supply is from T10, T11, T12, L1, L2, sir. So during the procedure, they will be giving irrigation fluid, which will distend the bladder. The patient will have discomfort if we don't block the nerve supply, which is supplying the bladder as well, sir. So that's why we like the level of T10.
That is very good answer. But another important thing is you have prostatic urethra and the distal urethra is there. The prostatic urethra is supplied again by L1, L2.
Okay, sir.
So T12, L1, L2 is the prostatic urethra is supplied, and penile urethra is supplied by S2, 3, 4.
Okay.
So plus prostatic urethra is being manipulated, so you have to have T12, L1, L2 have, plus bladder, as you said, there can be distension of the bladder. Stretching of the bladder can produce a lot of discomfort for the patient. So you require to have a T10 level of anesthesia. So that is always there. Now, how do you prepare this patient, and how do you induce your spinal anesthesia? What kind of drug you will be giving? What position you will be giving? So just let me know. How do you prepare?
So for preparation, first of all, I will get on the day before, I will get the patient's consent, informed written consent. I will ask for BP charting overnight because the patient is a known hypertensive, and I will ensure that the patient is asked to stop telmisartan the morning after.
Okay. The patient also has got a congestive cardiac failure, because these patients, many of these geriatric patients may have a PCF also.
Yes, sir.
So would you like to control that and then take up, optimize that and take up, or as a preparation?
Yes, sir. It would be preferable to optimize the patient.
That is also part of the preparation. Plus, relieving the obstruction, as already we discussed. That also will be a part of preparation. Okay. So you have done all these things, right?
Then I will also ensure that I will also inform the patient to have an adequate NPO. Of the
2 hours for liquids, pure liquids, and 6 hours for solid.
Okay.
And I will give the patient a low dose of anxiolytic for the night before, as well as aspiration prophylaxis. So.
Okay. So routine aspiration prophylaxis may not be required as such,
yes,
isn't it, for every patient? But if this patient is also diabetic and other reasons, obese, any chronic renal problem is there, then definitely aspiration prophylaxis is required, right?
And reservation of blood products as well, sir.
No, but do you routinely use?
Which one, sir?
What is the amount of blood loss that occurs intraoperatively?
Roughly, we expect around 500 ml.
Now, usually, how much it is based on the gram of prostate tissue removed?
Yes. 1 gram is around 7 to 20 ml, and per minute of resection 2 to 5 ml.
So usually per gram about 7 to 10 ml, isn't it?
Yes, sir.
So let us say it is about 60 or 90 grams.
Yes, sir.
So you expect almost nearly 1 liter.
Yes, sir.
So again, you should always never forget about maximum allowable blood loss based on the hemoglobin. So you talk like that only, depending on the prosthetic size and depending on the patient's basal hemoglobin level. So suppose if it is only 8.5 grams, you're not going to postpone the surgery because his hemoglobin is 8.5. You don't require to give him preoperative blood transfusion because it's not a transfusion trigger. So, but you estimate the allowable blood loss based on the prosthetic size and based on his hemoglobin, and that will make you to keep ready any extra amount of required blood products. Okay, right.
Yes, sir. Then on the morning of the surgery, I will again reassess the patient, and I will pay special attention to the patient's blood pressure and ensure that it is indeed controlled.
Yeah.
I will secure an 18 gauge IV line in the left hand, and after that, I will ensure that the operation that is prepared, machine is checked, and the relevant instruments for spinal anesthesia are available. Then after reading the patient inside, I will connect all ASA standard monitors.
And do you keep ready for any GR intubation?
Yes, sir. Yes, sir. We will always prepare for intubation.
Yeah, you have to prepare for complications.
Yes.
Isn't it? Especially TURP syndrome and pulmonary edema, you have to keep ready, isn't it? So you keep ready all anti-arrhythmic drugs. You keep ready furosemide. You keep ready a defibrillator, and keep ready for intubation, and also managing seizures if occurs intraoperatively.
Yes.
And also keep magnesium sulfate.
Yes, yes, sir.
Yeah, because hyperglycemia. So you may have to give magnesium sulfate is one of the drugs of choice. So that also you keep ready. So all these are the part of preparations. Okay. So now the patient is brought into the OT, right? What kind of fluid you are going to start for the patient?
Sir, I will start the patient on balanced salt solution like Ringer's lactate, sir.
No, is it Ringer lactate is ideal or normal saline?
Normal saline, sir. Normal saline.
Better to, that's what I told you on that day when we were discussing about fluids. Only in two situations you go for normal saline. One is the patients posted on TURP. Another is patients with upper GI tract obstruction, where they would have lost a lot of the hydrogen ions. So you go for normal saline only. Chloride ions also they would have lost. So usually in these are the situations. So TURP it is always better because expect a fall in the sodium levels. So better to give higher sodium. What is the sodium content in Ringer lactate and sodium content in normal saline?
So in normal saline, sodium content is 130 milliequivalents. In
normal saline.
Normal saline is 150 milliequivalents. In
154 milliequivalents.
154.
And Ringer lactate?
Ringer lactate is 125.
131.
131.
Yeah, 131. 111 of chloride, 131 of sodium.
Sodium.
Okay. Sodium is, we are concerned with sodium. So because normal saline has got a higher level of sodium, 154 milliequivalents, it is always better to have normal saline as the fluid of choice. Okay, you have started with the fluid. Now monitoring.
Monitor, sir. Heart ECG, lead 2 and lead 5. Pulse oximetry, non-invasive blood pressure monitoring, and temperature monitoring as well.
Yeah.
And
temperature.
Yes, sir.
Yeah, because these patients are highly prone for developing intraoperative hypothermia. Why intraoperative hypothermia that can develop?
Sir, because the irrigation fluid that surgeons will be providing might be of low temperature, might be cold, so that can cause hypothermia.
And,
not in a geriatric patient because of chance of autonomic neuropathy. Patient can have a loss of regulatory.
Yeah, because large amount of irrigating fluids are used. So that itself can produce, and if there is a prolongation of the surgery, definitely it can produce hypothermia is one of the complications intraoperative.
Yes.
Temperature monitoring is very important, and maintenance of normal temperature throughout the surgery is again another important task of ours. Okay, right. Then
And that's all some monitors.
You want to go for a low level of spinal anesthesia, you have to induce.
Yes, sir.
Make sure that you are inducing a low level of spinal anesthesia.
So we'll provide around 2 ml of 0.5% hyperbaric defusion for this patient to achieve a level of T10, sir.
Now, what is the position?
Position while providing the spinal, sir?
Yeah.
Lateral.
Lateral or sitting?
Sitting would be better, sir. So we can
because
ensure
you
that,
have to,
ensure
that is
low
what in the exam you will be asked. How do you make sure that you are getting a low spinal? Because you don't want the spinal anesthesia to extend high up. Because that can produce in these geriatric patients severe hypotension and all problems can occur. So it is very important that you restrict your level to T10. So it is always better if you give in the sitting posture.
Okay.
So that your sacral analgesia is also very effective with sitting posture. So gently bring the patient to supine, and once make sure that the anesthesia has effective anesthesia has occurred, then only you see that the patient is placed in the lithotomy posture. Okay. So and what are the problems you expect in lithotomy?
Sir, with lithotomy, first of all, since we are flexing the hips and the knees, sir, to a certain degree, because that can cause compression of the vessels and structures going in the present in the hip joints and as well as the knee joint.
Neurovascular problems.
Yes, sir.
Neurovascular problems.
Neurovascular problems, sir.
Okay.
Second thing is, because we are giving a lithotomy, there can be a venous return. If the patient is having heart failure or is having a previous history of IH, ischemic heart disease, he may not be able to tolerate a sudden venous return. That patient will start experiencing symptoms of fluor overload. So pulmonary edema might occur.
So you have to have modified lithotomy in such situations. And what on the effect on the respiratory system?
Yes, sir. Because of the lithotomy, there can be a pushing up of the diaphragm, sir. Because of the
FRC and vital capacity both
will reduce, sir.
Yeah, FRC will actually, there would have been an increased FRC in all these geriatric patients because of the increase in residual volume, but closing volume and closing capacity will be much higher. Any decrease in FRC, further increase in closing capacity, they can develop hypoxia. So that is another concern is always there with the lithotomy. You have to be careful. The third important thing is many times they'll be using a monopolar underwater diathermy.
Yes.
So they have to have a patient electrode also.
Yes, sir.
So you have to be very careful about this thing. His lower limb should not be touching any part of the metal that is used for lithotomy position.
Okay.
Because then he can have a lot of burns. Isn't it? So that is another very important thing about lithotomy. Every time this mishap has occurred. So these are things which you have to be careful as far as lithotomy posture is concerned. Okay, now everything is fine. You have started with IV fluids also. So level of block is up to T10. And you did not tell me about use of adjuvant. Any adjuvant you would like to use?
Morphine, sir.
Yeah, you can use morphine. How much morphine?
70 mics, sir.
Usually about 100 mics. 0.1 milligram. So you use regularly morphine in your
actually, we use buprenorphine.
Buprenorphine we use more often, sir.
Yeah, then you tell about buprenorphine only.
Okay, sir.
If you are asked about morphine, you can tell later. But what you use routinely, you can always tell. How much buprenorphine you are using?
60 mics, sir.
60 mics. One ampule of 1 ml of buprenorphine is how many micrograms?
300.
300 micrograms. So you are using roughly
0.2 ml.
0.2 ml.
Okay, right. You have used that also for post-op analgesia. Okay, now the other important thing is what are the intraoperative complications you expect? Before that, the irrigating fluid. Now, why they require irrigating fluid?
So the irrigating fluid for them is so that they have they're able to access the urethra easily. That is one. Second thing is so that whenever as they are resecting, fluid will bring out the prostate tissues.
Debris,
like,
sir, the
debris is
blood and the
brought
debris.
along. And
So
lot
there
of
has to be continuous irrigation of the bladder and then the area. Otherwise,
Yes.
they'll not be able to see anything.
Yes, sir.
So for continuous irrigation, they require an irrigating fluid.
To provide good visibility of the surgical site.
Yeah, that is what. So what should be the ideal irrigating fluid characteristics?
It should provide excellent visibility. It should not cause hemolysis. It
No,
should
it
not
should be,
conduct
you can start with, it should be isotonic,
isoosmolar,
transparent,
transparent,
and
does not
non-toxic.
conduct, sir,
non-toxic
non-toxic.
to the patient. It should not get absorbed and produced like glycine can produce glycine toxicity. So it should not produce any toxicity. And then it should not conduct electricity.
Yes, sir.
Otherwise, there can be burns of the bladder also if it conducts electricity. So that is another very important thing. Next is it should be very cost effective,
Yes.
not be very costly. Like Cytol is there, which is a combination of sorbitol and mannitol, very costly. And even mannitol 5%, quite costly it works out. So most often the irrigating fluid that we use is what?
Sir,
In our-
glycine, but in our institute, they also use normal saline, sir.
Normal saline, if you are going in for what kind of diathermy?
Diathermy,
So they use a bipolar diathermy.
That is what.
They're able to use.
One is going for a bipolar diathermy, then one can use normal saline because both the electrodes are there only where the surgery or resection is being done. Majority of the times it will be a monopolar, and when you are going in for a monopolar, you cannot use normal saline.
Yes.
That is what you should remember about. And even laser surgery, you can go for normal saline. Laser TURP. That is what, whether it is a monopolar, it is a bipolar, or a laser TURP. So these three different things. Let us say that they are using, and bipolar when they are using, since you are using a normal saline, chances of TURP syndrome is almost negligible. There is an advantage with bipolar. And also if the patient has a cardiac electronic implantable device,
yes,
that will not have any problem if you are using, if the patient is using a bipolar diathermy. Those are the advantages of bipolar diathermy. Let us say that a monopolar underwater diathermy is being used. So now definitely you'll have to use glycine, isn't it? So what is the percentage of glycine you will be using?
1.5.
1 point. What is the osmolarity of 1.5% glycine?
200 milligrams.
220.
220. 220 is the osmolarity. So, but it is hypoosmolar. Why not using isoosmolar glycine? How much is isoosmolar glycine percentage?
2.2%, 2.2%.
Yeah, 2.1%. 2.1 is isoosmolar. But why are we not using isoosmolar?
Sir, as the percentage increases, the transparency reduces. Sir. So
Yeah, turbidity. It becomes more turbid. That is why we don't use, though we know that we are using a hypoosmolar glycine. So still we have to go for 1.5% only for its transparency. And none of the irrigating fluids what we use routinely meet the ideal characteristics of or characteristics of an ideal irrigating fluid. But glycine almost have many of the ideal characteristics. That is the reason why still glycine is very popular. Okay. So what are the intraoperative complications you expect and how do you manage?
Sir, so intraoperatively, of course, we can expect one is a fluid overload, sir. So from excessive absorption of the irrigation fluid, patient can go for fluid overload. Pulmonary edema is something that we can also expect, especially in pediatric patients. Okay. Second thing is, of course, TURP syndrome is another. The onset of TURP syndrome can happen.
Okay, just enumerate all the complications, then we will go into each one.
Yes, sir. Apart from that, patient can also have other complications like DIC is one. Excessive bleeding, bladder clots also can occur in these patients, sir.
Septicemia.
Septicemia.
Hypothermia.
Hypothermia.
So these are additional. So usually this, especially this TURP syndrome, how do you avoid these things? What is rule of 60? Invariably, you will be asked about rule of 60.
So, rule of 60 is we have to ensure that the patient only, that the surgeon only operates for 60 minutes maximum. Only a maximum of 60 grams of the tissue should be extracted. Yes,
Okay.
we should ensure that the height of the irrigating fluid is 60 centimeters above the level of the patient, ensuring a 60 centimeter hydrostatic pressure. And that's it, sir.
This is what is rule of 60. But what are the other surgeons, his management to reduce the amount of or incidence of TURP syndrome? What he can, how he can, assist in decreasing the incidence of TURP syndrome? It is mainly, you see, you should not open the true capsule, because prosthetic sinuses are there inside the true capsule. So that is one thing you should always make sure. Second thing is repeated bladder irrigation. Because, the pressure gradient is mainly because of the pressure inside the bladder and the prosthetic sinuses. If this, bladder distension is made to be present for a long time, then, all the fluids from the bladder will enter into the prosthetic sinuses because the pressure gradient is created. So repeated evacuation of the bladder by the surgeon definitely will reduce, and not opening the true capsule, because prosthetic sinuses are present within the true capsule. He need not have to open the true capsule. If he doesn't open, then no prosthetic sinuses will be opened, absorption will not occur. So, and again, the number of prosthetic sinuses opening is also depends on the surgeon. So these things definitely the surgeon can assist. So suppose if TURP syndrome occurs, so how do you diagnose and how do you manage?
So with TURP syndrome, first of all, we look for the clinical picture. So with each level of hyponatremia, there will also be a certain signs and symptoms. So
why hyponatremia?
So because of it's dilutional, sir, because of the amount of irrigating fluid.
Actual sodium levels will not come down.
Yes.
It is mainly because non-sodium containing irrigating fluid we are using. That is why when you are using saline as the irrigating fluid, this problem will not occur.
Yes, sir.
Because there is no question of dilutional hyponatremia. It is only when you are using non-sodium containing irrigating fluids. And that too, when you are using a monopolar cautery, you cannot use sodium containing irrigating fluids because they conduct electricity. When you are using bipolar, then you can definitely use. So, okay, dilutional hyponatremia, and what else other than hyponatremia?
Hypertension, bradycardia,
osmolarity.
Hypoosmolarity.
Yeah, it is mainly because of hypoosmolarity and hyponatremia. All the problems of TURP syndrome occur. Okay, what are the individual signs of individual systems like?
So there is usually a triad, sir, of hypertension, bradycardia, and reduced mental status or altered mental status for this patient.
Okay. Followed by?
Sir, followed by seizures, coma, and followed by hypotension and seizures.
Hypotension, shock, and death can occur.
Death, yes.
As far as cardiovascular system and respiratory system is concerned. And cyanosis is another problem because severe hypoxemia can occur. And CNS, of course, altered sensorium, confusion, and death, isn't it? So these are some of the findings. So as soon as you think that the patient is going in for TURP syndrome, there is some amount of altered behavior. So how do you now manage?
Sir, so initially it depends on the levels. So if the patient is merely restless or agitated, then most likely that the sodium levels are around 120 or less.
No, should you ask for the surgeon to immediately?
I should ask the surgeon to
start hemostasis.
Isn't it? And you should change the fluid to saline.
Saline, yes.
So he should secure hemostasis, change this thing to saline. He should not continue with the irrigation of the same fluid. That is one thing, important thing. Okay. Then you immediately send the blood for
sodium
and ABG.
ABG.
Isn't it? So that becomes very important. Okay, so in the meantime, what you can give? The drug.
Diuretics, sir.
Always, furosemide. So usually 20 to 40 milligrams of furosemide you can give. Okay, so now you get a sodium, estimated sodium you can get. Okay, let us say it is about 120, 115 milliequivalents. Now what you do now? You have given Lasix and all. So, but still, you think that sodium may require to be corrected. How do you correct this sodium?
So we can first find out how much the deficit of sodium is, sir, using the formula.
What is your target of sodium correction?
120, sir.
120 or 125?
125.
125. Because 120 is still a borderline.
Okay, sir.
Anything less than, suddenly it can even come down to less than 120. Again, the problems can occur.
Okay.
So you target it to 125.
Okay.
So what is the formula you use to calculate the amount of sodium requirement?
Total body water into desired sodium minus the patient's measured sodium, sir. And total body water.
Total body water or,
Yes, sir. Total
in
body water.
compartment, you don't have sodium much.
Yes, sir.
So why should you go for total body water? That is why, many of the books give us 0.3.
Okay, sir.
Don't go for 0.6.
Okay.
Don't go for 60%. Go for 30%. That is enough because you have to be very careful in correcting the sodium also. Because rapidly, if you correct, what is the complication?
Cerebral edema, sir. Central pontine myelinolysis.
Yeah, central pontine myelinolysis. It is a lock-in syndrome. It can even go for fatality, quadriparesis, and very dangerous complication. So you should be careful how much you give sodium and correct it. So let us, I told you that his sodium is 115.
Yes,
so
sir.
correct it by another 10 milliequivalents.
Yes, sir.
Multiplied by his 60 kgs,
yes,
multiplied by 0.3.
Yes, sir.
So total requirement of sodium is around now about 300.
Okay, sir. So for this 300, we can use 3% NaCl, sir. In 3%,
Okay.
in 3%.
How much it contains? 3% hypertonic saline?
512 milliequivalents, sir, in 1 liter.
1 liter. 1 liter. Now you have to correct around just not 300. How much I got? 60 into 0.3 is 18. 18 multiplied by 10 is 180. So your correction requirement is 180 milliequivalents.
So we'll have to provide around 360 ml of 3% NaCl, sir, over a period of 24 hours. So we will divide 360 divided by 24, and we will give that amount, and we will ensure that the sodium level does not raise more than 1 milliequivalent per hour.
Usually now they are still careful, not more than 0.6 milliequivalents per hour. So you have to be careful. So in the olden days, we used to say up to 1.5 milliequivalents per hour was okay, but better not to go for more than 0.6 to 1 milliequivalent per hour. So that's how, you calculate the total requirement of sodium, and you can divide it by, so if I want to correct it by in 0.6 or say 1 milliequivalent, so 180 this thing you will have to correct, isn't it? Total or 10 milliequivalents you have to correct. So over 10 hours, minimum you can take is about 10 hours. And this 300 ml divided by 10 is 30 ml per hour. So you can go for 30 ml per hour. So that's how you calculate. Okay, that is how you treat this. If the patient develops convulsions, definitely you intubate, you
thiopentone, intubate, and
flex the patient, and then manage his the dilutional hyponatremia, isn't it? And osmolarity. Okay, so what about the blood loss? How do you calculate the blood loss?
Sir, with the blood loss, the ideal method would be we'll have to see the HB hemoglobin of the drained irrigating fluid as well, sir. So
hemoglobin of the drained irrigating fluid divided by the patient's hemoglobin into
total irrigation fluid.
Total irrigation fluid.
And that's how you know exactly how much of the blood loss, and you can correct it. How do you calculate how much fluid is absorbed? So these are some of the questions they'll ask you. How do you calculate? What is the formula? Pre-op sodium divided by
pre-op sodium divided by patients by
post-op
sodium
sodium
post-operatively
multiplied by
multiplied by the ECF
ECF
volume, sir, minus ECF volume.
ECF. So that's how either you weigh the patient and know the weight of the patient before. Now you weigh it, and that also you can get what is the total amount of absorbed fluid, or you go for this formula. So now pre-op sodium divided by post-op sodium multiplied by extracellular fluid minus ECF. So these are the things. And DIC is another problem in these patients. Why DIC can occur?
Because of dilutional
DIC.
sepsis. Due to sepsis, sir?
No, not sepsis, because some of the products that come out of
urokinase is released by the prostate during resection, sir, which
they can produce thrombin formation. That is why many times ideally you can even give before antifibrinolytic agent. That also will prevent this DIC formation. So sepsis is another problem. So you'll have to do go for a broad spectrum antibiotic and manage. Okay. So these are the things about exactly 7 we have completed TURP.
Yes.
Manage in just 1 hour. So I could have discussed more, but I want to restrict because other short cases also we are supposed to do. So any questions regarding TURP? You have any doubts?
Right now, as of now, no, sir. But I think I will have tomorrow.
Okay.
I have to think it through, sir. When I was reading, I remember having some doubts, but I'm not able to recollect at this point of time.
Okay, then
tomorrow's class, before that we'll have a discussion.
Tomorrow's class, I don't know what case tomorrow you are going to present.
Burns, sir.
Burns contracture.
Burns contracture for difficult diagnosis.
Yeah, mainly it's more of a contracture release than burns as such. So okay, then we will meet tomorrow at 7 o'clock, 5 o'clock. Okay. So we'll try to finish off the burns contracture tomorrow.
Okay, sir.
Okay, so that next the other short cases will be presented by your juniors.
Yes.
Okay, very well done. All the best for your exam. So
thank you, sir.
I think you will not present.
No,
so
sir.
Somebody else will be presenting.
Yes,
okay, all the best for your exams.
Thank you, sir.
You people have really doing very well as far as practicals is concerned. Your theoretical knowledge is good. So naturally, I don't expect you have to have problems in theory also. But concentrate, read, work hard, do well in your theory and practicals.
Thank
okay.
you, sir.
Thank you, sir.
Right. We'll meet tomorrow. Right.
Yes.
Okay.